Let me introduce the next speaker, Dr. Varsha Baste. It's a proud privilege to introduce Madam, for she has been a fertility specialist for the last 30 years. She's a director of Baste Maternity Hospital and Pushpa Fertility Center, and she has to her credit the first ICSI PGD baby born in North Maharashtra in the year 2003. And she was a past president of OBGY Society Nasik in 2014. She was a chairperson of Foxy IAEC between 2019 to 22. And she was a recipient of prestigious Dr. Anandabai Joshi Award amongst V First 3 Puraskar by Honorable Governor of Maharashtra, Foxy Champions of Foxy Award, Foxy Excellence Award for outgoing Foxy chairperson, and she has organized many national international conferences, participated in numerous national and international conferences. With this brief introduction, I present Madam to you all.
Pleased and I'm really happy to be here in Vizag. This is the first visit of mine to Visakhapatnam. The history of Visakhapatnam I have studied in my childhood, and I was really fascinated to visit this first ancient port of India. And I'm really thankful to Dr. Jyoti, Dr. Kavya, and the team, and Vizag, Dr. Niharikan sir, for inviting me and giving me this opportunity to talk in front of this August gathering. Thank you. I've been greeting from Maharashtra, Nasik. That is the city of winery. My topic given by Jyoti and Kavya is really good. It is pertinent to be discussed, very much important and devastating to the patients also, and concern for the doctor also. So recurrent pregnancy loss. It is when more than two consecutive losses occur prior to 20 weeks of pregnancy and affects 1 to 2% of women. About 2 to 4% of RPL is associated with parental balance, structural chromosomal rearrangement, reciprocal and or Robertsonian translocation, and mosaicisms. The etiology is mainly altered maternal environmental conditions like infection, anatomic, endocrine, genetic, and immunological abnormalities. Embryonic defects like chromosomal abnormalities. The etiology mainly of dear chairpersons, because I have seen they are so well read and educated and highly qualified chairpersons here. Parental chromosomal abnormalities, untreated hypothyroidism, uncontrolled diabetes, uterine anatomic abnormalities, and antiphospholipid antibody syndrome. So this is very important slide. The organization of care. Pregnancy loss is a significant negative life event, and repetitive nature of repeated miscarriage may intensify the grief experience. Studies have mostly focused on women, and there is need for studies on emotional impact even on men. Clinician and clinic should take the psychological needs of couples faced with RPL into account when offering and organizing care for such couples. Now, I am going to talk about this topic into two portions. One is we will be just highlighting the ASHRAE guidelines. They are not laws, but they are guidelines. You may or may not like it, but many people have come together from different countries and they have formed the guidelines. So this is the pictorial summary of recommendations for investigation and treatment of couples with recurrent pregnancy loss according to ASHRAE. You may or may not like it, but they are there. So recommended tests are antiphospholipid antibodies. You have to give low dose aspirin and prophylactic dose of heparin. Then thyroid abnormalities, you have to treat hypothyroidism with levothyroxine. Uterine abnormalities, effect of surgery is inefficient, evidence based. Then few tests which are to be done just as a for record, or like genetic test, genetic counseling and information on PGT to be given. Immunological test, no specific treatments are available. Sperm DNA fragmentation test, the lifestyle advice to men, and antioxidants. Then screen for hereditary thrombophilia. So these are the recommended but not very essential tests. And not recommended tests are other immunological tests or metabolic or hormonal tests also. For all these days, we have to give lifestyle advice, tender loving care, and prophylactic vitamin D. That's all. That is what Eshrey says. So, what according to Eshrey, which therapeutic intervention should be offered to couple with repeated miscarriage? We are not saying RPL nowadays due to genetic and chromosomal causes to increase live birth. There is a limited evidence for pre-implantation genetic testing in couples with RPL shows no clear benefit of treatment. Couples with results of abnormal fetal and parental karyotype should receive genetic counseling. Then what about thrombophilia? For women with hereditary thrombophilia and history of repeated miscarriages, we suggest not to use antithrombotic prophylaxis unless in the context of research or if indicated for venous thromboembolism prevention. For women who fulfill the lab criteria of antiphospholipid Apla syndrome, have a history of 3 or more pregnancy losses, we suggest administration with low dose aspirin 75 to 100 milligram per day starting before conception. And once she gets pregnant, then we have to add unfractionated heparin or low molecular weight heparin when she gets pregnant. The guideline development group, which is very important for Eshrey, suggests offering anticoagulant treatment for women with 2 pregnancy losses and antiphospholipid syndrome only in the context of clinical research. Now, what about immunological background to increase the live birth rate? No immunological biomarker except for high titer antiphospholipid antibodies can be used for selecting couples with RPL for specific immunological treatments. But these are guidelines, these are not the laws. At our center, we do give this immunological and this the immunological treatment, like we segregate lymphocytes from autologous lymphocytes and we give it to patients, getting good results. Also, activated cytokine release serum we are using and it is also giving us good results. Then what about metabolic and hormonal abnormalities to increase live birth rate? Overt hypothyroidism arises before conception and during gestation should be treated with levothyroxine for such patients. There is conflicting evidence regarding treatment of this with levothyroxine with patient with subclinical hypothyroidism and RPL. The treatment of the women with subclinical hypothyroidism may reduce the risk of miscarriage, but the potential benefit of treatment should be balanced against risk. Patient with subclinical hypothyroidism get pregnant again with after miscarriages. THS should be done in early gestation and hypothyroidism should be treated. Patients with thyroid autoimmunity or antibodies, they get pregnant again. Thyroid and TSH levels should be checked in early gestation. Hypothyroidism should be treated with levothyroxine. There is insufficient evidence to support treatment with levothyroxine in euthyroid women with antithyroid antibodies and outside a clinical trial. But at our center, we do use this precursor of L-thyroxine and that along with this L-toxin or levothyroxine, it gives better result because we are adding something extra instead of only giving levothyroxine. Now, what about metabolic and hormonal abnormalities to increase live birth rate? There is insufficient evidence to recommend use of progesterone to improve live birth rate in women with RPL and luteal phase insufficiency. I am not saying this, Eshrey guidelines. There is insufficient evidence to use SCG to improve live birth rate in such patient and luteal phase insufficiency. There is insufficient evidence to recommend metformin supplementation to prevent pregnancy loss with glucose metabolic defects. But bromocriptine treatment should be considered with such patient and hyperprolactemia to increase live birth rate. Preconceptional counseling is a must and prophylactic vitamin D supplementation should be given to all such patients. Now, control ovarian stimulation by HMG could be beneficial for decreasing the chance of next pregnancy loss because we are increasing the quality of oocyte. But there is insufficient evidence for its use in PCO patient according to Eshrey. What about such patients with uterine abnormalities to increase live birth rate, whether histoscopic septum resection has benefit should be evaluated in context of surgical trial in women with RPL and septate uterus. Metroplasty is not recommended for bicorporal uterus with normal cervix. Uterine reconstruction is not recommended for hemiuterus. There is insufficient evidence in favor of metroplasty in women with bicorporal uterus and double cervix. Insufficient evidence supporting histoscopic removal of submucous fibroid or endometrial polyp in women with RPL. Surgical removal of intramural fibroid is not recommended. There is insufficient evidence to recommend removing fibroid that distort uterine cavity according to ESHRE guidelines. Insufficient evidence of benefit for surgical removal of intrauterine adhesions also. After histoscopic removal of intrauterine adhesions, precautions to be taken to prevent recurrence. In second trimester patient with losses, suspected cervical weakness should be offered serial cervical sonographic surveillance. The importance is given on cervix. In women with singleton pregnancy and history of recurrent second trimester loss attributed to cervical weakness, a cerclage should be considered, and there is no evidence that this treatment increases perinatal survival. So now, cervical measurement, short cervical length by TVS between 16 to 24 weeks is a must because it is an accurate predictor of recurrent miscarriages. A threshold of cervical length at 24 weeks is defined as 2.5 centimeter, 2.25 mm with 37% sensitivity and 92% specificity. Knowledge of cervical length has also reduced the risk of preterm birth before 37 weeks. Cervical length less than 15 mm reported as most optimal cutoff with 81% specificity and 83% predictive for true miscarriages. Cervical elastography is also given importance in abroad, but we are not doing it. It is not very well available easily. We all know short cervix, funneling of the cervix, or bulging of the membranes. That tells us about the cervical weakness. Ability to accurately predict and prevent RPL in second trimester remains one of the crucial challenges in modern obstetrics. Recent systematic review has confirmed the accuracy of fetal fibronectin. Also, it is used for preterm predicting the preterm birth. And transvaginal sonography for cervical length is a predictive value of in symptomatic patients for recurrent miscarriages. Adding absence of this is not that much important, but we have to do the cervical weakness evaluation. Now, what are the preventive measures for second trimester miscarriages? Progesterone and cervical cerclage. Progesterone is a magic pill. Natural progesterone offers complementary anti-inflammatory, anti-modulatory, uterine quiescent action. How does it affect? What is the action? It inhibits oxytocin activation, prostaglandin production, inhibits GAD junction, inhibits cervical ripening by down-regulating production of cytokines, inhibits connexin 43, gap junction protein. So what is the optimal dose, base troop and formulation? Available as natural progesterone from soya beans and Mexican yam roots also can be used, but we have to add progesterone. The half-life is increased with metabolite like allopurinol. Micronization decreases the particle size and enhances dissolution of progesterone. Also offers greater bioavailability up to 33% and improves the half-life kinetics from 4 to 18 hours following oral injection. Now we are getting patients from remote places. They are not ready or they are not comfortable for vaginal insertion of the tablets or injections. So this is the very good option for them. So better tablet once a day because it has got prolonged action and it is really benefited for the patients coming from remote places. Vaginal progesterone can reduce the risk of spontaneous abortions. A systemic review and meta-analysis in 2016 of randomized trial said that the women with progesterone support with short cervix reduce the frequency of spontaneous RPL less than 24 weeks by 37% and reduce the composite neonatal morbidity and mortality by 41%. So it is really good to use progesterone. Now, cervical stitch or stitch in time. Indicated cerclage in first trimester, history based with questionable indications, benefits and controversial intervention. Prophylactic cerclage history suggests with short cervix on sonography. Rescue cerclage, patient presents with already dilated cervix, bulging membrane, but no sign of pain, infection, or bleeding. Second trimester, miscarriages. Anatomic abnormality responsible for 10 to 15% of recurrent abortion. The causes may be congenital defects in Mullerian duct fusion like unicornuate, bicornuate, septate or double uterus, acquired intrauterine adhesions, uterine fibroids, endometriosis or cervical incompetence. Defect of Mullerian fusion like double uterus, septate or bicornuate uterus, about 12% cases suffer from recurrent abortions. Implantation on septum leads to defective placentation. Asherman syndrome, intrauterine adhesion due to previous curettage can lead to early miscarriage because of less vascularization. Transvaginal ultrasound is useful for the diagnostic. Hysteroscopic resection of septum and division of adhesion in Asherman syndrome is indicated. Submucous fibroid managed by myomectomy. So this is the way we diagnose them. Now, cervical insufficiency or incompetence. Painless cervical dilatation with ballooning of amniotic sac into vagina followed by rupture of membrane and expulsion of fetus occurs around 16 to 24 weeks for such patients. What is the cause? Congenital, maybe developmental weakness of cervix or uterine abnormalities, acquired iatrogenic because of DNCs, induced abortions, vaginal operative surgery of undilated cervix, amputation of cervix or cone biopsy, multiple gestations or prior preterm birth. Now, diagnosis. Repeated missed trimester, painless cervical dilatation, escape of liquor amni followed by painless expulsion, that is indicative of cervical weakness. Internal examination, passage of 6 to 8 agar dilatation beyond internal os when she is not pregnant, we have to diagnose it that way. Funneling of internal os seen in HSG. During pregnancy, clinical digital painless cervical shortening and dilatation is indicative. Sonography says us if the short cervix less than 25 mm and funneling of internal os more than 1 centimeter. How will you manage? Surgical management, usually around 12 to 14 weeks. The procedure reinforces the weak cervix by non-absorbable tape. Mind well, friends, don't use simple Prolene or other. You have to use Mercilin tape because she is a case of repeated miscarriages. So you have to give good competency to the cervix. So this is the incompetent cervix herniation of the membrane and competency is restored after encerclage operations. So contraindication, infections, rupture membrane, vaginal bleeding, severe uterine irritability or cervical dilatation more than 4 centimeter. Two methods we know, McDonald and modified Shirodkar, also abdominal laparoscopically. Success rate is around 80 to 90% if done properly. Now, types of cerclage, history indicated definite history of 3 previous cerclage losses we have to give irrespective of cervical condition. Ultrasound indicated short-ended cervix or early funneling and also the history. Examination indicated for rescue cerclage performed after cervix is fully dilated, cervix is found dilated or also called emergency cerclage. So, McDonald operation, we do anterior knots, the modified cerclage, we take an incision and subserosal layer and the knot is posteriorly. Transabdominal cerclage, rarely done in cases of repeated failure of vaginal approach. Cerclage is placed at the level of isthmus and we have to take her for C-section. Now, what is the post-operative care? Patient should be in bed for at least 2-3 days. Progesterone supplementation, weekly injection of 70-alpha hydroxyprogesterone caproate, 500 mg intramuscular, do not give 250 mg. Patient is asked to avoid sexual intercourse. Removal of the stitch should be around 37 weeks or earlier if the pain starts or feature of abortion appear. If the stitch is not cut in time, uterine rupture or cervical tear may occur. What are the complications? Slipping or cutting through suture, choriamnitis, rupture of membrane, cervical scarring, dystocia require cesarean section. What is the prognosis of recurrent miscarriage? The overall risk of miscarriage is around 20 to 30, 25 to 30% irrespective of number of previous spontaneous miscarriage. But the overall prognosis is good even without therapy. The chance of successful pregnancy is about 70 to 80% with effective therapy, but we have to be very vigilant. Now, rescue cerclage is bed rest needed? Not at all, but you have to be cautious for 1 or 2 days. recommendation of rescue cerclage, no clear evidence about gestation at which cerclage is most, anytime you can give, but this the cerclage is done before 20 weeks. If it is done emergency cerclage, likely to result into preterm delivery before 28 weeks. Decision to take rescue cerclage beyond 28 weeks is individualized. Age of neonatal survival is and availability of NICU facility. Rescue cerclage is not done in prevent in infection, bleeding, or uterine contraction. Discussion with neonatologists and gestational age should be around 16 to 28 weeks to get better outcomes, and counseling is also very important. So these are the nice guidelines when to give rescue cerclage. If there is a history of preterm birth or miscarriages, repeated miscarriages, cervical length less than 25 between 16 to 24 weeks, go ahead and give do the cerclage. Now, progesterone deficiency in RPL, very important. Luteal phase defect is a condition in which inadequate production of progesterone occurs, consequently results in inadequate development of endometrium. Several studies show less progesterone level seen in patient of RPL named luteal phase defect in recurrent first trimester spontaneous miscarriage. Corpus luteum is needed for maintenance of hormonal support in first trimester until trophoblast is capable of assuming function. So that time you have to give external support with progesterone. So what are the treatment options in recurrent miscarriages? Antibiotic with anticoagulant, supportive care, progestrogens. These are the effects of progesterone in recurrent miscarriage. Progesterone also has large range of effect on uterine blood flow, uterine artery endothelium, and smooth muscles of uterus to promote implantation and pregnancy development. So it is very, very important to add progesterone. Now, choosing the right progesterone, criteria for doctors is different. Patient will say convenience, ease, result, and availability, cost also effect. What are the formulation? We know injectables, vaginal, oral. Oral micronized, and oral dydrogesterone. The which one to use? Now, oral micronized, there is a poor bioavailability, higher dose is required. There are side effects like drowsiness and sedation, and also not approved in pregnancy indication. There are zero publications. It is available only in India, but I will say go ahead and use it because it is needed for certain sector of patients. Oral dydrogesterone backed by evidence. It is approved in pregnancy indication, threatened or recurrent miscarriage, and also progesterone deficiency. More than 600 published articles are there and available in 100 countries all over the world. So better option because it has greater bioavailability, around 28%, effective at low dose 10 milligram. Even Foxy recommends use of dydrogesterone, and negligible side effects because it minimizes unwanted effects. Also, detrimental effects of metabolites like adverse effect of pregnancy outcome with oral micronegestrone and low pre-implantation rate is seen with oral, that is what is the study says, but oral dydrogesterone major metabolic support, metabolite supports the pregnancy to conductive of successful pregnancy. Also, the nitric oxide synthesis improves the endometrial receptivity and pregnancy outcomes. So, this is the evidence of comparison of this both. Global guideline recommendation favor dydrogesterone in repeated miscarriages. European Progestin Club guidelines for treatment of recurrent miscarriage 2015 said that for women presenting with clinical diagnosis of recurrent miscarriages 3 or more, there is reduction in rate of miscarriage with the use of dydrogesterone. What does Foxy says? Foxy published the statement in 2015. The use of progesterone. Dydrogesterone to be used 10 milligram twice a day till 20 weeks of pregnancy according to Foxy. What does ASHRAE guidelines say about recurrent pregnancy loss? In 2017 they published that vaginal progesterone during early pregnancy has no beneficial effect in women with unexplained RPL. There is some evidence that oral dydrogesterone initiated when fetal heart action can be confirmed may be effective. So these are the guidelines and these are the reports or evaluation and their suggestion. But we have to be practical, we have to see what our patient needs and we have to take a call what our personal practice and our experiences tell us to go ahead and use whatever formulation is you are compatible with. Thank you for your patience here. I am coming from Nasik, from this place, and I am going for the post of Foxy Vice President West Zone. मेरा चेहरा देखना और सिक्का मारना. Thank you.